Dr. Kanof is a principal at Health Policy Alternatives and previously served as the Director of Healthcare at GAO and served in a variety of leadership positions at CMS, including Deputy Director of Payment Policy. She received her medical degree from the University of Kansas and her master's in public health at Harvard University. Good to see you again.
Good to be here. I thought it was a test as I was listening to Kate answer some of your questions, because sometimes I actually got them right too. So I thought that it was a major accomplishment that I'm standing here after reading 2,400 pages of a final rule and actually got some of the messages. Kate and I are going to overlap a little bit. I will pass through those, but you'll have these slides, and then I found that MIPS and APMs are not something I can immediately comprehend at once. It takes many, many hours. My other charge, though, was to talk about the physician fee schedule rule, because although I know there's a lot of focus on MACRA and MIPS and payment incentives, you shouldn't forget at the end of the day, you still are paid off of Medicare Fee Schedule, and there are RVUs, I call those the building blocks. Whether you're in an APM or whether you're self-employed or whether you're employed by a hospital, the world does go back to the RVUs. My time at an insurer, we would pay a percentage off the RVUs. I know there are some academic physicians that are somehow reimbursed a percentage of their work RVUs. So let's not forget about the physician fee schedule. Don't ask me too many detailed questions about the physician fee schedule. While it was in 2,400 pages, it is 1,400 pages, and it was the gift that came out on Wednesday evening. So we'll move along. This is what I'm going to do, and again, I will move quickly through things that I think you've already heard. But I don't want you to think that MACRA is just MIPS. You need to remember that not only did MACRA repeal the SGR, but it also did some significant changes to the conversion factor that we're going to talk about. As I said, it maintained the building blocks of the physician fee schedule. It created MIPS, it created APMs, and it did put a halt to the CMS initiative to transition all global surgery codes to zero-day codes. So you've got some ups and downs. Here's the conversion factor. July through December of 2015, the update was 0.5%. 2016, the annual update is 0.5%. 2017 through 2019, the annual update is 20.5%. And then interesting things happen in 2020 through 2025. There's no annual update. So in fact, there could be a slight decrease if you put in budget neutrality. But who knows what will happen next week, and who knows what will happen in 2020. And then 2026 and beyond, there's two conversion factors. Those that are qualifying APM participants will have an annual update of 0.7%, and everyone else will be 0.25%. You've learned this. You've seen this. I want to, though, emphasize to you that it's budget neutral. You have to have winners and losers, and so you'll see, at least at the end when I talk about the impact, actually, CMS is actually only projecting within the MIPS world about $199 million for distribution if they base an assumption that 90% of MIPS eligible clinicians hit the zero mark, submit some quality. So we're not talking about a lot of money. You have to you're dependent upon somebody not doing well to get an increase. The $500 million for the exceptional performers, that's additional money that has been appropriated. I don't want to forget, though, on what's coming up in MACRA. And starting 2018, somehow we're going to have claims reporting requirement to facilitate attribution for resource use measures. Claims are going to need to include information about the care episode, the patient condition, the patient relationship code. And I listed here the possible relationship codes. And to date, when CMS has put out RFIs asking about this, they have focused on all of this. So they're looking not just to attribute, as they do now in the value modifier, by trying to find out, okay, who had the most E&M visits. They want to know all this type of information. And all of this is supposedly based off of a quality measurement development plan. And I just wanted you to realize that it exists and that these are the domains. So as you're thinking of creating additional measures, or you're thinking about what should your registry collect, these are the domains that CMS is interested in.